We've been doing a post-marketing surveillance study for about a year now, and it's about 50,000 patients who are derived from a Department of Defense database. And people tend to think of that as Veterans Administration. It is not. The Veteran Administration is like your bias would be, a bunch of older veterans, high smokers, obesity, and that sort of thing. The Department of Defense database is the insurance company for the military. So it's all the family members and kids, so you have equal numbers of women, you got young people, you got old people, normal rates of smoking and that sort of thing. So we looked at that data set, and we pulled out all the people who were on Rivaroxaban for 15 months. The Department of Defense database is really tight. Because it's an insurance company, if you go to a different hospital, they still get the bill. So the advantage of that is loss to follow-up is approximately zero, because the only way you get loss to follow-up is you absolutely disappear. So it's a tight data set, and the electronic case report form for the DoD is also tight. It's one of the best in the US. So for getting data and feeling secure that it's accurate, this is a very good way to go. We've been playing with this database now for a year, and we've been plucking out different subsets we felt might have higher risk or less effect, and so the one we've looked at most recently was the diabetic subset. And there's about a third of these people, 27%, are diabetic, and so we looked at that, and we looked at how many had a major bleed. And the way we go after that is we use an algorithm that's called Cunningham, that's designed for going to identify major bleeds in large data sets. And it uses a whole bunch of factors, and it's been validated. And from that, we were able to find out how many bleeds there were. And there are about 500 bleeds in the diabetics of all those people. When you look at that, they have the same trends that all the prior studies have done, in that GI bleeding is the dominant bleed. Intracranial hemorrhage is very unusual, and fatalities are very low. And so the only thing statistically significant compared to the non-diabetic is more GI bleeds. But if you take the fatality rate, it's 0.09 per 100 years, and you have to put it on a 100-year scale because exposure is important. If you're on it for a week, probability of catching a bleed is pretty low. If you're on it for years, you might. What I've been trying to do is put this in similar comparison to stroke risk, because doctors tell me all the time, oh, I don't want to put my patient on an anticoagulant because I'm worried about the bleeding. And so I've put this number together. So if you look at the CHAD score, and you're CHADS 2, your risk of bleeding in the next year, of having a stroke in the next year is 3%. That's 3 per 1 year. So we got to make these numbers the same. So you can work the 3 per 1 year to 330 per 10 years, or 300 per 100 years. And you can round that 0.09 to 0.1 per 100 years. So it's 0.1 bleed per 100 years, or 300 strokes. What would you want to do if you were the patient? This is a no-brainer. So when doctors tell me that they don't get why I'd want to use an anticoagulant in this patient, it's because you'll have to give 300 people a stroke or one piece and bleed, because you're going to give a patient something. And doctors who don't figure out this should go buy lottery tickets, because the odds are about the same. They're just not good. Well, I think that's the whole point of data. When studies come out, a randomized controlled trial is the best trial to show whether the drug works or not. But the problem with randomized controlled trial is they slice it up, so you can't be over a certain age. You have to have no more than certain number of morbidities. And you end up with a population that doesn't look like a population that you really treat as a doc. So the advantage of these post-marketing surveillance studies is this is the real world. It doesn't matter that this is the best pill in the world. If for some reason the patient can't take it, it's useless. And so when we look at these real-world trials of diabetics, we really do know the fatal bleed rate's 0.09 per 100 patient years in the real people you treat. And the advantage of the military health database is it looks like real people. It looks like the United States. It's not some crazy database that is biased in some fashion. We picked out the diabetic group for a significant reason, and what it is that if you look at the CHAD score, so or CHADS VASC, which is the preferred score, each one of those parameters gives you a risk of stroke. We've taken the same database and several different databases and validated this, that the higher your CHAD score, the risk of bleeding goes up in a linear fashion. So while the risk of your stroke is going up, so is the risk of bleeding. And the important piece here is that at no point does the formula ever favor not giving anticoagulants. The risk of bleeding is always markedly lower than the risk of stroke, even though it does increase. So if your CHAD's a 4, you have a pretty significant risk of bleeding, but you have a huge risk of stroke. And so stroke always wins in these analyses. And so the reason we picked out diabetics is because the D in CHADS is diabetic, and we wanted to make sure, and we've been doing each one of these, trying to figure out who is an appropriate or not patient. Because if we found a group that had disproportionate bleeding, you'd want to know that and avoid that. And so far we have not found that at all. And we've looked at renal failure, and we've looked at age, and we've looked at diabetes, and so we're trying to figure all the reasons that we should or should not use this. I think what we can say is that diabetics have an increased risk of bleeding. It's about 3 per 100 patient years. That's your risk of bleeding. Compared to the patients who are non-diabetics, it's about 1 less than that, about 2. So you do get some more risk, but because the risk of stroke is so high in diabetics, the formula still markedly favors treatment over abstinence. We are doing one called Mercury. This is a randomized controlled trial of Rivaroxaban versus standard therapy for patients presenting to the emergency department with PE. The idea is that if you're on Rivaroxaban, you can go home. So we're discharging pulmonary emboli, which is not so unique in the rest of the world, but in the United States it's just not done. Emergency department sees a PE, and we tend to just admit them. So this will be done in hopefully about a year, and I hope we have the opportunity to sit down and talk about that, because that's going to be, if it works as we expect it to, it's going to be a game changer. Now we're looking at cancer patients, because nobody really, we don't have a lot of data on anticoagulant prophylaxis or treatment for patients with cancer. And so this is the next piece we're going to look at, because the advantage of that is the large cancer studies aren't that large, and they mostly compare warfarin and Lovenox. And so having some insight about that would be helpful, because nobody really likes Lovenox. It is the recommended drug, but it's shot every day at home, and that's not much fun. So we think that we're going to be able to demonstrate efficacy and safety. So hopefully one day we'll get done, but it's not anywhere in sight, because what we're finding out is that before we had warfarin, which is a terrible drug. They call it rat poison because it was. And the challenge of that is that nobody wants to be on rat poison for very long. And so we stopped treatment like in 6 months, or 3 months. As soon as we can get you off this drug that's a pain to take and causes trouble, and intracranial hemorrhages are more common with warfarin. As an emergency doc, they come to me, and I hate warfarin because I've seen so many intracranial hemorrhages with it. I have never seen an intracranial hemorrhage from a NOAC, and I work in the largest trauma center in the 3rd largest city in the United States. So the whole class of drugs is better. So now we have this better drugs, which is going to completely upset the apple cart. Whereas we used to try to get you off these drugs, we know that your 10-year risk of having a repeat DVT is about 40%. If you live long enough, you're going to have another DVT once you've had one, and maybe you'll have a PE next time, and those can be fatal. DVTs, not so much, but they can turn into PEs, and that's a problem. So the studies on all these pathologies that we know are benefited by some kind of anticoagulation have now got to be repeated with a safer version of the treatment, and consequently it's going to completely change all our guidelines, and this is going to take 20 years to work out.